All right. Welcome to the LSRT study group number 10. Moving right along here. There's going to be a few more, yes, but I appreciate you guys being here and trying to learn this X-ray stuff. It's really cool and it's really important and something that Sterling wants you to do. So I'm happy to be a part of this and doing this with you guys. So let's get started here. Let me move on to another screen here. And we'll, okay. All right, guys. Hope you can see that okay. But yeah, we're going to talk about image acquisition today. We're going to do a little reviewing, first of all, what we talked about last week. We talked about radiation protection, the three principles that are key in radiation principles are time, distance, and shielding. Shortening the time of our exposures, increasing the distance when we're taking the images, or anybody else that's in the room. We want them as far away as possible. And shielding, use shielding when you can, for sure, especially if the patient asks for that service. We need to provide that. Okay, so it's just one thing you got to remember: three basic principles of radiation safety are time, distance, shielding. Okay. We talked a little bit about different types of lead protection that we use. Thyroid shield, lap lead apron plus a full lead apron. The minimum required thickness is 0.5 millimeter. I'm sure that's probably a test question somewhere along the way. It'll give you 0.25, which they do sell 0.25 lead aprons. But the minimum thickness that we need to work in the medical field is 0.5 millimeters. Okay. Dosimeters, we talked about two different types. Well, we talked about more than two, but the two main ones are TLD, the thermoluminescent, and the OSL, the optimally stimulated luminescent. Here in these clinics, we use a TLD. We talked about how they should be worn. They should be worn between the torso and the shoulder on either side or in the middle. I wear mine with my lanyard. Fetal monitors, if you're pregnant, we need to get you a fetal monitor. Just let us know and we get that ordered for you. It'll be at your clinic shortly. Those are to be worn at the baby level and underneath the lead apron, just so we know exactly what that baby's being exposed to. So the control dosimeter needs to be kept where the control badges are kept because it detects background radiation. So just a real quick review on occupational dose, fetus dose, and the general public dose. Just be familiar with these. The occupational dose is 2.5 or 0.25 REM or 12.5 millisieverts. The fetus is 500 millirem or 5 millisieverts during the entire pregnancy. For the general public, limit is 100 millirems or 1 millisievert per calendar year. So, the radiation dosage isn't that high, really. Us that work around it, it's a little bit higher for sure. But we still need to take care of ourselves. So, lead shield care, we need to inspect them yearly and clean them quarterly. Just make sure they look okay. If you're starting to see cracks or big creases in them, let us know so we can replace those. We want them to be fully operational when it comes to protection from radiation. So always store them hanging up. Don't fold them. Second best option is laying straight, but try to keep them hanging. Yeah, we also talked about 4 body habituses: asthenic, hyposthenic, and hypersthenic. Okay, just be familiar with those. All right, let's talk about image acquisition. Okay, we're talking about when the image is actually brought to the digital screen or the X-ray film. We're going to talk a little bit about both of them. Image acquisition involves exposing a patient to a beam of X-ray photons, which then interacts with their tissues and structures, with the resulting shadows being captured on the image receptor, okay, or film or digital screen. So we've talked a lot about X-ray generation, how X-rays are produced. So it's generated inside the X-ray tube and emits a beam of electromagnetic radiation. The intensity and energy of the X-ray beam is totally up to us. We control that. And there should be no surprises when it comes to that. But we control that by KVP and mass. Okay. We've also talked about the interaction with the patient. So the X-ray beam passes through the patient's body where different tissues are absorbed with variable amounts of radiation. This is called attenuation. Tissues with higher density, like bone, absorb more X-rays, thus appearing lighter on the image. While tissues with lower density, like soft tissues, lung tissue, stuff like that, they absorb less energy, so they're going to appear darker on the image. It's all about attenuation, different densities in your body, how the X-ray passes through there, and what it's like when it reaches the film or the image receptor. So we're going to talk about the image receptor next. The X-rays that pass through the human body are captured on a radiologic film placed within a cassette, and this cassette that it's placed in contains intensifying screens. And we don't do this in our clinics. We're completely digital, but you need to know kind of how the film works in old X-ray, because there may be questions about it. But yeah, the cassette that the film goes in actually has intensifying screens. The intensifying screens convert X-rays into light, which then interacts with the film emulsion, and it forms a latent image. Okay, pretty interesting process. So once that latent image is on the film itself, it is processed chemically. You go into a dark room, you take the cassette apart, grab the film out of there, and you put it in a processor, and it runs it through there. It takes a minute and a half or 2 minutes, and different chemicals actually process that picture, and then your X-ray falls out the other side. Pretty interesting. At that point, you know what you ended up with. Not like we've got it today where we shoot a picture and bam, there it is, and we can do different manipulations with it. With film, you can't do that. It's sink or swim. Either your film's good enough or it isn't. So digital imaging, fortunately, that's what we do. Computer radiology uses an IP plate to store the latent image, and then it's read by a laser scanner, and then it's transferred over to our computer screen. A little bit longer process than regular digital imagery, but still pretty cool nonetheless. But like I say, we don't use that one either. The one we use is DR. So when we're ever asked by any surveyor or inspector, we are DR, or digital radiography, which uses a detector that directly converts X-rays into electrical signal, which is then digitized and displayed on our computer screen. Okay. The advantages of that is image processing and display. It's immediate. There's no processing chemicals or anything like that. It just pops up there on the screen, and if you've got enough density and enough information, you can manipulate that picture and make it look how you want it to look. So we'll talk a little bit more about that a little bit later today. So let's talk about some factors that affect image quality. There's a lot of them. So geometric factors, meaning source to image receptor distance, the distance from the actual X-ray tube to the image receptor. Okay. Object to image receptor. So OID, this is the space between the body and the IR. Okay, that's OID. And if you have too much OID, you're going to actually have some magnification or some distortion of your picture. And focal spot. Focal spot is the area of the anode where the negatively charged electrons come across and collide with the anode. And that is what we call the focal spot. Okay. So things that affect image quality continued. Technical factors, KVP, mass, exposure time, those all affect how your picture is going to look. Patient size, tissue density, and positioning as well have a huge impact on the way our images look. And you guys are going to get to the point where you'll be able to look at a patient and have a pretty good idea of what you need to shoot that patient at. So image processing parameters, contrast, brightness, and noise reduction. That's pretty neat stuff, actually, how you can make your pictures look just with the software that we're working through. Spatial resolution, you're going to hear this a lot. It's the ability of the system to differentiate between two nearby objects, or a measure of the smallest detail that can be distinguished on an image. Okay, this is crucial for visualizing, detecting subtle abnormalities. Okay, so yeah, spatial resolution, the ability to differentiate between two different things. That's what that is. Distortion, any alteration in size or shape or spatial relationship between structures on an image. And we'll look at some examples of distortion here in a minute. Focal spot, we talked about that. What that is, it's where the cathode sends the electrons over and it collides with the anode. That area is the focal spot. Okay. Now the actual focal spot is that area. Okay. Then the effective focal spot is what's left after it hits that area. It goes down through the tube. It's what the patient actually sees, how much of an X-ray beam they're getting. That's the effective focal spot. Okay. So factors affecting focal spot size are the angle of the anode and the size of the filament. Okay, we know that the filament is a tungsten coil that heats up and causes thermionic emission and sends those negatively charged electrons over to the anode. There's actually two different sizes. One's a longer one, one's a shorter one. It has everything to do with the amount of electrons that are boiled off. We only use one in our machine, so it's just one size fits all type, and they work pretty well. So tube filtration, we've talked about inherent tube filtration. The stuff is actually there to absorb low energy protons. Okay, and that's what tube filtration is. Beam restriction, we've talked about collimation a ton, how your image quality is changed when you don't collimate, and we'll see some examples of that as well. Patient motion, both voluntary and involuntary, affect your image for sure. Motion will degrade the image quality and can misinterpret, pathology can be misinterpreted. So it's so important that we have our patients holding still and holding their breath and not moving. Okay, you are going to get some involuntary movement, but the X-ray happens so fast that most of the time you can't detect it. The anode hill effect. This is an interesting phenomenon, actually. The variation in intensity across the X-ray beam. So the cathode side is higher intensity than the anode side. It has lower intensity. This variation is due to the angle of the anode target and how X-rays are absorbed while traveling through the target. And I'll explain this a little bit more in detail coming up, but just know that the anode hill effect is the energy on the cathode side is stronger than the energy on the anode side. So we know the anode is negative No, that's right. The cathode is negative, the anode is positive, okay, positively charged, which is just the opposite. Uh, so yes, more power, right, at the cathode end, less power at the anode end. Tube angle, detector angle, and body part angle, that can affect your image big time. You can get foreshortening and you can get elongation, either one, just by angling your tube, right? Artifacts, and we know artifacts being metal that's on the body, and sometimes wood or keys or anything like that that's going to cover up anatomy. We need to make sure we're removing that from patients so that it doesn't occlude any pathology that we're trying to look for. Okay, let's move on a little bit. Those are all things that can affect image quality. So here's an example of patient motion. Okay, these are really interesting x-rays. We've got an L spine and a lateral chest x-ray. You can see on the lateral L spine, it's not sharp at all. You can't detect sharp edges of bone. You can barely see the joint spaces, and you know the spinous process. You just can't see anything really well because it's so blurry, and that has everything to do with movement when the x-ray was taken. So if you were to get either one of these images out of an image you just shot, you would be retaking that image because it's just not diagnostic. This lateral chest x-ray, a lot of motion. I would assume that they were still breathing when they took the image. So yeah, that one had to be redone. I just want you guys to know what that looks like. But that's what patient motion looks like on an x-ray. So be aware of that. And if you're starting to see motion, yeah, make sure that patient's holding still. Image distortion, angle, elongation. So you look at the picture on the right, that is an elongated foot. That has to do with the angle of the x-ray tube is a little bit long. So we're getting a longer x-ray, right? Or the bones are elongated. It's kind of neat looking. And this oblique foot here, we've got a bad angle as well. I mean, this is the same foot. It's just we've got a bad angle on the one on the outside, and it's actually elongated. It made that foot look way bigger than it actually is. Pretty cool stuff, though. All right, examples of poor collimation. We talked about collimation a lot. And this is a good example. So the one on the left is good collimation. This is actually a picture of a lumbar spine. And you can see the good collimation picture. You can actually see the spinous processes, right? You can see good joint spaces. You can see the facets really well. It's just a sharper image. And then you go over to the one that's not collimated well, and you can't see the spinous processes as well. You know, you can see more anatomy, but it's just not as sharp as the one that is collimated. And that's just a good example of how good collimation will make your pictures look better. Less scatter radiation means better picture. So pretty cool picture. Okay, now overexposure versus underexposure. We need to know what we're looking at when that happens. If we take a picture and this one on the left comes up, it's dark, you know, pretty poor recorded detail, and it just looks like there's too much going on there. That's an overexposure. We need to back off on the technical factors there. Now the one on the right is underexposed. Little tidbit for you. So on your chest x-rays, your PA chest x-rays, you ought to be able to detect different thoracic vertebral bodies. Now this one on the right, you cannot. You can't even see. It's just a light blob through there. That just tells you right there that it's underexposed. You see the soft edges around the lungs. Just not enough power to go through there. One good thing about digital is this one on the left, you could probably make look decent because there's enough density and enough information there that you could you could make that image look better post-processing. This one on the right, though, you're going to have to retake that one because there's not enough density to work with, not enough information there. But just know what over and under exposure looks like. And we're going to talk about another way that you can see that here in a minute. So, okay, artifacts. Okay, artifacts are fun and artifacts are cool because they look cool on X-ray, but in the grand scheme of things, they're not a great thing. They can cover up stuff like, if somebody's wearing a big chain, it could cover up a lung nodule that's just getting started, and your X-ray is going to be negative. But if there's a lung nodule under there, it's something that maybe a doc would like to keep an eye on. And if you don't know it's there, you can't. So whenever you get an image that there is an artifact in the region of interest, you need to retake that picture without the artifact. Make sure their chain's off, bra, earrings if you're doing a C-spine, belly piercings, or anything like that. Just make sure that your patient's clean before you take an image. Okay, here's one of my favorite artifacts. It's actually a static artifact. I know when I first started, I got one of these, and you pull that picture up, you expose it, and this is what you get. Man, you're thinking, what on earth does this patient have? He's in big trouble, right? But it's actually this artifact is done pre-X-ray taking. It's usually because the area is really dry, and you pull an X-ray film out of a box and it creates static, and that's how that image actually comes to pass. Now digitally, you're not going to get this. I mean, I think it is possible, but digitally it's just not going to happen. Okay, so pretty neat looking picture though, right? Kind of cool. You pull that up and you'd be like, man, what is wrong with that person? Okay. So sorry about that, guys. Okay, anode hill effect. We talked about this a little bit, how the anode side is weaker than the cathode side. So we got the negatively charged electrons coming over from the cathode and impacting the anode here at the focal spot. So what happens is the electrons on the anode side are actually absorbed somewhat by the anode. So there's going to be less coming out the anode side than there is where the direct contact on the cathode side of the anode. Okay, so this is basically what the anode hill effect is. So less on the anode, more on the cathode. Okay, and let me show you how that can help you out. Here is a picture of a humerus. Okay, now this first picture right here, they obviously took the picture with the patient's head towards the anode, and you can look at your X-ray tube in your respective clinics, and you can see which one's negative and which one's positive, right? So we know that the negative one is going to be the cathode, and we know the positive one is going to be the anode. So if you have something with a big differentiation, somebody with a big shoulder kind of like this and a little bit smaller elbow, you're going to want to put that shoulder on the cathode end because you're going to need more power up here than you need down here. Okay, and that's what they did here. This first picture, the shoulder was up by the anode, and they're grossly underexposed at the shoulder area, and they're overexposed at the elbow area. Now, once they flip the patient and put the patient's head towards the cathode and the elbow towards the anode, you got a more uniform picture there because there was more energy coming through that thick shoulder than the little elbow. Okay, so that's the anode hill effect, and you can use that to your advantage at some point. I just want you guys to know what that is. It's just more power at the cathode than there is at the anode. Okay. All right, shape distortion, elongation, foreshortening, and this isn't that big a deal. I used to work in post-op stuff and the operating room a lot as a rad tech, and we would have to take a lateral hip picture, a portable, uh, and we'd have to be able to see the entire prosthetic, which is tough on a cross table lateral. So you would actually angle against the angle. Normally you'd try to match that angle, but you try to overmatch that angle, and it's actually going to foreshorten that bone a little bit so you can see the entire prosthetic. And that's just an example. We don't do those here, so you don't have to worry about that. But yeah, I just want you guys to know what shape distortion is, how a bone can look different when your tube's angled differently or your patient's angled differently. That's when the shape distortion starts, okay? All right, so you'll know, I'm going to take you to the next picture here. When you take an x-rays, at least on the blade view system, down here on the left bottom, you'll see current EXI, and it gives you a number. That's what I want to talk about. Depending on the vendor of the machine that you're using, they're going to use different acronyms. EXI is the blade view one, and that means exposure index. I'm not sure what the S or the REG means, but those are different numbers for different vendors. Okay, so what happened is these vendors have come up with a number system to help us check our accuracy of our exposure settings, right? So here's a list of the exposure settings for the Paxis 100 unit. So school, if you 1500 and 2500, extremities 1200 to 1500, chest 1500 to 2500, abdomen 25 to 3500, and pelvis 3000 to 4500. And that's your index number that you should be getting. So let's test that out here. So this is a lateral wrist, so it's an extremity, and we got a 1420. So let's go up here on extremities, 1200 to 1500. So we're right there in between those two recommendations. So that is the the software telling us that the right amount of X-ray energy was used for that body part. And it's also a good way for us to tell what kind of exposure that patient is getting. So if we'd have taken that and we'd have come out with like a 700, that would mean that our image is underexposed. However, if we took that picture and we come up with 2,200, it's way overexposed. So that, if you're having problems telling if a picture is under or overexposed, that's a good way to tell is with your S number or your EXI number. Just see if you're within those parameters for that machine, for that particular body part, and for that particular exposure. You can tell whether you're over or underexposed. Anyway, it's just, you guys don't, just know what that is. You don't have to memorize these or anything. And just know that these are manufacturer's recommendations. If your image that you expose doesn't fall between those two parameters, it's not the end of the world, okay? If your image looks good, or you can post-process that image to look good, it's going to be okay. All right, but do pay attention to those. Kind of see where you're, and most of our techniques are going to be pretty close. So, okay. All right. So technique charts is the last thing we'll talk about today. APT, so anatomically programmed techniques. This is what most of our clinic sites have. They are built in to our control panels. Awesome, right? You want to do a finger, you go there, you select finger, and bam, it gives you a technique. That is what an APT chart is, okay? It's automatically there for you to shoot. Very, very important for the type of x-rays that we do and for learning, actually. But technique charts, I'm talking the ones that are on the wall that are written out. And the ones that I send out have 3 different body sizes, child, average, and large adult, and what the technique should be for each one of those sizes. And that's just something you learn going forward. You know, because patient size is variable, which means variable techniques are used sometimes. Um, and like I say, that's in your individual chart in your clinics, or should be. So fixed versus variable, you'll have to know what that is. So fixed is where you leave the kV constant while adjusting the mass. Variable is where you leave the mass and adjust the kVp. We do more fixed than variable. I just find it a little bit more user-friendly, and your pictures will look a little bit better. And we'll talk more about that. I'm not going to get too deep in that today. But just know what an APT chart is. It's the actual chart that's programmed into your X-ray unit. Now, there is a clinic that had their APT techniques erased, the Rock Springs Clinic, and I commend them because they're using a wall technique chart and changing their techniques for every different body part, and they've done a great job with it, trying to get those APTs back, and we're almost there, so I can come out and put those back on. But yeah, good job, Rock Springs. Okay. All right, just a few considerations affecting the technique work. Casts, these days everything's mostly fiberglass. You'll see a plaster one every now and then. But a rule of thumb, say you need to x-ray a wrist that has a cast on it. Provider doesn't want to take that cast off until they see how that bone's looking. Is what you do is you choose your wrist technique on your APT, and then you're going to double the mass. Okay, you're just sending some more radiation photons there. Okay, so just remember, double your mass when you have a cast from the original technique. Pathological factors, more dense pathologies will need more technique or more mass. Tumors or masses or anything like that. Lesser pathologies like this says emphysema. Emphysema, you're going to need much less technique. If you ever shoot a chest X-ray on somebody that has emphysema, then you use a regular technique, the lungs are just going to turn out really dark, just because it's one of those pathologies that don't have a lot of density to them. So if you take your picture, you see that it's really dark, they've got emphysema, you'll either have to cut your mass in half or decrease your dose a little bit in order for those lungs to be readable. So, okay, age of the patient, bone age. That geriatric patients lose some bone density, and that you need to change your technique in that case too, because you don't need what you need to get through a normal bone versus a geriatric bone. Same thing with kiddos. Their bones are really soft, not real dense yet. Just need less dose. Okay, and we've all heard of BMI, body mass index. We need to increase our exposure via KVP or via mass to penetrate larger tissue properly to get a diagnostic images. So, as X-ray people, we need to pay attention to BMI. And I do it more by look than number. I can usually look at a patient or have somebody tell me the weight and height of a patient, and I can get you right there in the ballpark on what kind of technique is going to work okay. So if you ever have that question, get a patient in there that you're not sure if you need to change your technique or not, just let me know, and we can run through that real quick and get you headed in the right direction. So anyway, I think that's all I have for you today. I appreciate you guys taking the time to watch this and taking the time to learn this stuff. It really means a lot to me. Makes me feel like what I'm doing is worthwhile, and I hope that you guys will enjoy this. I know sometimes it's hard, but just learn this stuff and take that test. It'll be worth it, I promise. Anyway, thank you guys for coming. I'll see you guys again next week. and we'll talk about more fun X-ray stuff. Have a good week. See you later.